Bismillahirrahmanirrahim. I welcome all of you on today's session. I am Professor Shahid Sarwar, Professor of Medicine and Gastroenterology at Allama Iqbal Medical College. This session is primarily meant for postgraduate students as well as undergraduate students and family physicians, house officers who are likely to see medical emergencies and medical conditions in their daily practice. So let's start with today's case, and then we will build up on that. So today we are going to talk about a patient who is 40 years old, and he has presented with epigastric pain, which is going on for the last 6 hours. Now, the first thing to think whenever you confront a patient is, before taking history, is to think of the possible differential diagnosis. So when we see a patient with epigastric pain, which has a short duration, there's a list of differential diagnosis that comes into our mind, depending, and it is based on the prevalence of these diseases: peptic ulcer disease, pancreatitis, cholecystitis, myocardial infarction, aortic dissection, appendicitis. Even diseases like diabetic ketoacidosis, porphyria, they can present with severe epigastric pain. So there has to be a number of points in history which we need to focus while taking history from this particular patient. Obviously, we'll talk about severity, radiation, type of pain, its association with meal, fact of change of posture. We know in relation to pancreatitis why this question is important. Then the history of retrosternal discomfort and diaphoresis for somebody who's 40 years old is meaningful. Similarly, we'll talk about there is previous history of similar pain or not. Is he diabetic or hypertensive? So all these things need to be explored in the history. What we see is that the pain is severe, it's continuous, non-radiating, and he hasn't taken anything ever since for the last 6 hours since he's having the pain. There is no past history of food-related discomfort. He complains of diaphoresis, but there is no chest discomfort. He had vomited twice at home and has not passed any stool or fluids for the last 6 hours. There is no history of NSAIDs, any other medication, diabetes, hypertension. These are not there in this history. Once we did an examination, he's a middle-aged man with visible distress, with tachycardia. He has got positive portal hypertension. His pressures are on lower side, and his respiratory rate is around 18. And on general physical, nothing else is positive. Abdomen is scaphoid, moving with the respiration, inverted umbilicus, but it is markedly tender in epigastrium, and there is no shifting dullness, and bowel sounds are also absent. And what we can find on other examination of the other system is that there is reduced chest expansion on the left side, with stony dull percussion on the left base, with absent breath sounds, and reduced vocal resonance in the left base as well. Now, once we have taken the history, have done the examination, obviously we'll go back to the same differential diagnosis, that the list that we created right at the start at the presentation of the patient. And you can conclude that because pain is epigastrium, it improves with sitting up, it is associated with vomiting, absolute constipation, and there is no history of diabetes, hypertension. So our differential will now be narrowed down to the possibility of pancreatitis, cholecystitis. Due to his age and male gender, still the myocardial infarction will remain the possibility, despite the fact that the risk factors are not present in this patient. And you will not forget our aortic dissection, which can present with epigastric pain, with hypotension, with diaphoresis, with a very critical situation that needs not to be missed. Now, how should we proceed? And what test will we like to perform in accident emergency? So this is the list that should come straight into your mind: CBC, ECG, ultrasound, amylase lipase, and X-ray chest. And if you go back to the differential diagnosis list that we had, you can very well understand why we have planned for these tests right away in the emergency. His ECG was done, which was perfectly okay. And we can see that there is homogeneous opacity in the left lower lung zone with loss of costophrenic and cardiophrenic angles, meaning that this is pleural effusion most likely on the left side. This is an ultrasound which was done, and you can see there is an opaque opacity within the lumen of the gallbladder, which has got a shadow suggestive of stone in the gallbladder. Now, this is what his complete blood count and liver function test and renal profile are showing. The noticeable thing is the raised TLC, mildly deranged LFTs, and ESR of around 40. But what pointed us toward the diagnosis is amylase and lipase. That is much higher than the normal value. So the lesson till this time to learn is that never miss this particular acute diagnosis, and you will not get this diagnosis if you do not suspect pancreatitis in patients coming to emergency in epigastric pain. So that's the diagnosis. We all know pancreas is a very important organ which is lying between the C loop of the duodenum, and it's got a lot of function related to digestion of the food as well as obviously endocrine functions which are critical to the life. And we all know that once pancreas get inflamed due to any cause, what happens is that the enzymes which are in inactivated form within the pancreas, they get activated and they start digesting the pancreas itself. That's what leads to acute pancreatitis, and that's what leads to the clinical manifestation of this particular disease. What can lead to the pancreatitis? We need to remember that the two major causes, either alcohol or stone in the common bile duct, the biliary pancreatitis. These are the two most common causes. Apart from that, there are less common causes, which we'll talk about. And then still 5 to 10% of the patients will remain idiopathic where we'll not find any cause. So 40 to 70% will find gallstones. And the importance of this is the once you are done and recovered out of acute pancreatitis, you need to refer this particular patient to the surgery. Alcoholic pancreatitis need a heavy consumption of alcohol over a period of time, at least for 5 years, more than 50 grams per day. Otherwise, the usual social intake of alcohol is not going to lead this complication. Then we have less common causes like hypertriglyceridemia, hypercalcemia, drugs, and malignancies as well. Few genetic disorders like pancreas divisum, annulus pancreas, they can also end up with acute pancreatitis. Then there's sphincter eye dysfunction. Post-ERCP pancreatitis is very typical. Around 5% of patients are going to develop. Then we have a relatively newer entity, the autoimmune pancreatitis. And if all is negative, we also need to go ahead with genetic testing because few genetically transferred diseases can also predispose the person to the risk of acute pancreatitis, like TFDR, SPINK gene, and trypsinogen, cationic trypsinogen gene mutation. How do these patients present? The classical presentation is epigastric pain. It is present in almost all of the patients, but radiation to the back is a feature which only be seen in 50% of these cases. And the history will be of hours to days, not of months. Then it may be associated with nausea, vomiting, distension, tenderness, restlessness, agitation, depending on the severity of the pancreatitis. On examination, the most important thing to note is the signs of dehydration, tenderness, and then there are a few critical signs which points toward the gravity of disease like Gray Turner and Cullen sign. Bowel sounds are mostly absent right at the start, and patients are likely to develop left-sided pleural effusion, as we saw in the patient that we started our case with. This is Cullen sign and is a sign of hemorrhagic pancreatitis. It's a sign of a very severe pancreatitis. And this is how the Gray Turner signs looks like. Both are the signs of hemorrhagic pancreatitis. So how do we diagnose? These are the 3 parameters, and 2 out of these 3 will make the diagnosis. Typical history, more than 3 times raised amylase and lipase, and the third thing is imaging, characteristic findings on imaging. So if you can come up with 2 of these features, you can diagnose, label your patient as acute pancreatitis. Word of caution about these amylase and lipase because they have some limitations. Obviously, the amylase is the one which rises early but settles early as well. And there are situations where it can be normal even with the pancreatitis, and there are a long list of conditions which can lead to false positive raised amylase level. So whenever interpreting these results, always keep the possibilities of ischemic and intestinal perforation, mesenteric ischemia, cholecystitis, and all these things can also lead to raised amylase. Lipase is much more specific, and obviously it has a longer half-life, but there are still the conditions which can lead to false rise in lipase levels. So it means clinical presentation, biochemical test, and if both are not positive, then I will need an evidence on imaging as well. And that imaging would mean the best thing to diagnose acute pancreatitis is CT scan. But you don't generally do it right at the start. If you have good enough evidence in the form of clinical presentation and raised amylase lipase, then you don't do it right at the time of admission because it's mostly recommended after 2 to 3 days and is meant to detect necrotizing pancreatitis, complications of pancreatitis. So here you can see a cross-sectional image of the CT scan and you can see how the pancreas normally looks like, because it's a very smooth outline, homogeneous density on the CT scan that you can see. And once the patient develops acute pancreatitis, either it is swollen, its size is larger, but it is enhancing and there is no necrosis, or it may look like this. Here you can see, despite being a contrast in a CT scan, the contrast is not being picked. It's a big hypodense area, which is showing the necrotizing pancreatitis. So CT is a very important and useful test for making diagnosis. MRI has its own place. There are a few advantages with MRI. It can pick a stone of more than 3 millimeter in CBD, which may be missed in CT scan. Then pancreatic duct abnormalities are better identified and delineated in MRI. And thirdly, you can perform a T2 image to diagnose necrotizing pancreatitis without giving the contrast, especially in a patient who had got renal insufficiency where giving contrast is not an option. So these are the situations where you may opt for MRI. So how do the patients of acute pancreatitis progress? Remember, majority of these patients are going to resolve by themselves. Maybe 90 to 95% patients are not going to develop any complication. They are going to settle by themselves. But there is a certain percentage, around 10%, 20%, who are going to have complications. And the initial complication, first 48 to 72 hours, which you worries about, is multi-organ failure. And the second complication is necrotizing pancreatitis. So there 10 to 20% patients are going to develop necrotizing pancreatitis. Even out of those necrotizing pancreatitis, still 60% of them are going to have steroid necrosis, where it will settle itself and which has a very low mortality. The major thing that we really worry is either multi-organ failure right at the start or an infected necrosis, because then it's a longer protracted clinical course that you may face in these patients, and their mortality still remains around 15 to 25%. So you can understand majority of the patients are going to settle by themselves. But at start, you will have to treat every patient as a potential patient with necrotizing, with infected necrosis of the pancreas. And that's the only way of saving those 10, 20% patients who are likely to have complications. So a few terminologies which we need to remember: interstitial pancreatitis if there is no necrosis, and necrotizing pancreatitis if you have evidence of necrosis on imaging. Then if there is a fluid collection around the pancreas, less than 4 weeks, you will call it as acute peripancreatic collection. But if it goes beyond 4 weeks, you call it as pseudocyst. Then if there is necrosis, initially you call it as acute necrotic collection. But beyond 4 weeks, it is called as walled off necrosis. So these terminologies need to be remembered because these are based on timelines. Another thing, I talked about multi-organ failure as this is the most lethal complication in initial 48 to 72 hours. That's how you define multi-organ failure. You can see it basically comprises of circulatory failure, respiratory failure, renal failure, or blood loss, that is hemorrhagic pancreatitis, more than 500 ml in 24 hours. If you get 2 out of this patient has multi-organ failure, and it means that you are dealing with a critical patient who can end up with critical and grave outcome. Then another staging system that we all need to remember is Atlanta staging system. This basically is based on presence or absence of multi-organ failure and presence of or absence of pancreatic necrosis. If both of these things are not there, then this pancreatitis is mild. If patient has multi-organ failure, but it has recovered within 48 hours and or there is pancreatic necrosis, you will label it as moderate pancreatitis. But somebody with multi-organ failure, which is going beyond 48 hours, this is a patient with severe pancreatitis. So there are different ways of staging that we've talked about: mild, moderate, severe, edematous, or necrotizing. That these are the terminologies which should be used properly. But the limitation with the Atlanta score is that needs 48 to 72 hours to decide that the patient has developed multi-organ failure or not, there is necrosis or not. But right at the time of admission in emergency, you need to make decision that where should I take the patient? Should it be admitted in the general ward or in high dependency unit, or he is a candidate for ICU care? So for that, this BICEP score is much more helpful. It's a basically mnemonic for raised blood urea nitrogen, impaired mental status, systemic inflammatory response syndrome, age more than 60, and pleural effusion. If you have 0 to 1 parameter, you can manage it in general ward. If it 2 to 3 parameters means a high dependency unit, and more than 3 parameters means that the patient should be managed in ICU care, because then the chances of mortality are much higher. And briefly, what is SIRS? You can see, we all know this is systemic inflammatory response syndrome. 2 out of these 4 features will be labeled as systemic inflammatory response syndrome. So just to summarize what I have talked about, the progress of this particular disease is that initially at the time of admission, I will use biceps score to decide how to manage this patient. But for first 48 hours, my main focus will remain the avoidance of multi-organ failure, because that's the lethal complication that patient can develop. Once beyond 48 hours and there is no multi-organ failure, then your focus will shift to the presence or absence of necrosis. That is important. And even in necrosis, it's the infected necrosis which worries us most because of its critical course, because of its higher mortality. And beyond 4 weeks, you will label either pseudocyst or walled off necrosis in case patient has developed this particular thing. So the timelines are important to remember while managing these patients. How should I manage? As any patient who is being critically admitted in emergency, airway, breathing, circulation, pain relief, and hydration. These are the primary things that you do for every patient. But the most important thing for acute pancreatitis is aggressive hydration right at the start, right from the start of admission. And you need to use crystalloids for that. Why? Because I'm trying to avoid problems in patients who are likely to develop, in fact, necrotizing pancreatitis, because in that case, patient can have severe dehydration, can have circulatory insufficiency leading to multi-organ failure, because the fluid is being lost in the third space, in vomiting, in diaphoresis, in inflammation. So if you ask me one important thing regarding the management, it's aggressive hydration of the patient with the monitoring of his intake, output, and all those things, because this is what is going to save you from a very difficult, long, protracted course of illness in patients with pancreatitis. Then there are a few things which are stressed more early. Nutrition is stressed in patients with acute pancreatitis. If patient's bowel sounds have returned and his passing flatus, you will start with the liquids and will build that up as per the tolerance of the patient. But in situations where patient's ileus is not settling, his bowel sounds are returning, people have used nasogastric or nasojejunal tubes to start enteronutrition. The concept behind is very simple, that because it is felt that the nutrition of the intestinal epithelium is dependent on whatever we are taking orally. And once you make patients nothing per oral, then this epithelial lining starts getting damaged, and there is more risk of translocation of infection from the gut into the third space, in the outside, where necrotizing pancreatitis, in case it is necrotizing, will get infected. So there is a lot of evidence to suggest that if you start an early enteral nutrition for these patients, there are less chances of developing infected necrosis. That's why this thing is stressed so much, that patients should be started on enteral nutrition as early as possible. And obviously, you are going to monitor that patient for multi-organ failure, respiratory failure, circulatory, and all these with your routine lab tests. Should I use antibiotics? No, it is strongly discouraged. And fever, high TLC in initial part of the pancreatitis is an evidence of inflammation. It's not evidence of infection. It is only used in patients who have developed infected necrosis, not even in sterile necrosis. So how will I determine that? That will be based on clinical progress of the patient. If his high-grade fever is persistent, his TLC count is rising, his bowel sounds are not returning, abdomen is tender and obviously distended, and you find necrosis on CT scan, you should start suspecting that this necrosis is probably infected. And in that case, you need to aspirate, you need to take sample from that, send it for culture, and then you can start for the antibiotic. So the first most important thing to remember in management is aggressive hydration. The second most important thing is the avoidance of antibiotics that we need to do. The third most important thing that I've already talked about is early enteral nutrition that needs to be taken care of in the patients of acute pancreatitis. If we need to use antibiotics, which antibiotics? Obviously, carbapenem group is the drug of choice. The other options are quinolones and metronidazole. Do I need to perform ERCP urgently in patients with acute pancreatitis? The only urgent indication for urgent ERCP is presence of stone, evidence of stone in CBD with evidence of cholangitis. In that case, you have to perform an urgent ERCP. Otherwise, if you find a stone and there is no evidence of cholangitis, you may wait for a few days till settling of the patient's condition, and then you have to remove that stone, but obviously in that case you can wait. So just to give you an idea how to handle a pancreatic necrosis, because if somebody has necrosis and you are suspecting infection based on his clinical condition, his TLC count, and the progress of the disease, then you will have to get a CT guided FNAC. If it is sterile, you will wait and you may repeat this particular fine needle aspiration after 5 to 7 days if the patient is still not improving. If it is infected, you have to start with antibiotics and aggressive antibiotics with all the rest of the management, supportive care, and avoidance of multi-organ failure that we need to do. And if patient still fails to settle, then comes the role of surgery in these patients of necrotizing pancreatitis. Few slides, that's one slide just to show how to handle this infected necrosis or pseudocyst. These are the two complications which are associated with pancreatitis. They can be very well managed with endoscopic ultrasound, guided drainage and stenting and relief. And this is something which will avoid interventions and surgeries and like that. So the indication for surgery is where there is failure to improve with antibiotics in a patient with infected necrosis, and drainage of pseudocyst if it is not possible endoscopically. And obviously you will have to go for cholecystectomy in somebody who has got biliary pancreatitis, or somebody with pancreatitis and evidence of CVD of gallstones should have cholecystectomy to avoid recurrence of pancreatitis. Once the patient has recovered, never forget to work up for underlying etiology and prevention. We have already talked about the possible causes like stones, alcohol, hypertriglyceridemia, hypercalcemia, drugs, and then autoimmune pancreatitis. This needs to be worked up and have then we will treat the underlying whatever cause we identify for acute pancreatitis. So in summary, acute medical emergency, it's an acute medical emergency, and the most common cause is either gallstones or alcoholism. Diagnosis needs clinical history, raised amylase lipase, or imaging evidence of pancreatitis on imaging studies. Management is focused on pain relief, good hydration, and antibiotics if indicated for these patients. End organ failure and infected necrosis are the major complications that you may find in the patients of acute pancreatitis. Thank you very much.